I will bring them so that you can have an official account of what you got. All right? So we're talking about the heart. You got your two atria, your two ventricles, the SA node, the atrial nodal tracts, the AV bundle, the AV node, the AV bundle, the left and right bundle branches, and the Purkinje cells. They're going to stimulate, so here's the delay. Stimulate both atria to contract, and that's my PQRS, all right? That's this. Atrial depolarization. Then there's a delay at the AV node, and then the QRS wave, which is ventricular depolarization. So repolarization of the atria is hitting within here. Now, why is that important? Because when we're talking about ventricular contraction, when we're talking about ventricular depolarization, coronary arteries will be contracted down upon from the outside. Just like the vasovasorum feeds the outer wall of the blood vessels, especially the larger blood vessels, well, the coronary arteries do the same damn thing. They're feeding the heart, but they're coming from the outside going in. Make sense? Just like the vasovasorum, they got to do the same thing. Blood vessels have to branch off main vessels to feed then main vessels.
Coronary arteries will be...
Branches off main vessels have to go ultimately to feed the wall of the main vessels, guys, right? Because they can't steal oxygen away. The smooth muscle that's in the walls of the blood vessels can't steal oxygen away from tissue that it's meant to deliver oxygen to. It would defeat the whole purpose, wouldn't it, guys? Does that make sense?
Yes, sir.
It does, right? Just like you wouldn't want the lung to steal oxygen away, right? As blood is flowing from right side to left side. You see? Sure enough, it does. It does. Just a small amount. It does. Because the lung has priority. However, the majority of oxygen is fed by a separate set of blood vessels that will feed the lung. So the lung has a dual blood supply. It's got the blood supply that's running from left side to right side heart. It's also got its own blood supply that's feeding the oxygen it needs. So that it doesn't see this whole huge drop in oxygen. So now, the coronary arteries, it's interesting. Because if I have to feed the heart from the outside, then that means the blood vessels don't come from anywhere else but the great vessel. So when you look at the aortic arch, if I draw the aortic arch into here now, I'm going to erase this, guys. Okay? So this is just kind of like a review for you, because this is stuff you should know. Now, if I then draw in the great vessels, so, and let me do it in, I apologize, let me redo it. This time I'm going to do it so that I have inferior vena cava, superior cava, right ventricle, because it's deoxygenated. Everybody follow? And then left side, left atria, and then left atria, left ventricle. And off of here, remember, you got your pulmonary trunk. And then behind that, but coming from this side over, is going to be right behind you. Is going to be your aortic arch. So now, let's erase the pulmonary trunk. Let's remove it. Let's cut it out. Everybody follow me now?
Yes.
So you cut away the pulmonary trunk, and lo and behold, you see this beautiful structure coming right out the left side. And that's called the aorta. Well, the aorta actually has a few pieces. Right here, it's ascending. Did everybody see that? Here, it's an arch. When it gets back here, it becomes descending aorta. It's on the thoracic wall. Becomes the thoracic aorta. Did everybody hear me? Ascending aorta, aortic arch, descending aorta, thoracic aorta. When the thoracic aorta crosses the diaphragm, it becomes the, what do we call this region? Abdominal. So what are we going to call it? Abdominal aorta. Make sense, guys? When it hits the pelvis, what are we going to call it? The common iliac. The common iliac, because it's right on the ilium. You get me, guys? The structures are right there on the ilium. Sure enough, you got an external and an internal. Internal goes inward into reproductive structures and GI structures, and the externals go out to the leg. When it passes the inguinal ligament, then what do we call it? It's in the, what? What do we call this bone? The femur. So we're going to call the artery femoral artery. Sure enough, there's a deep femoral artery and a superficial one. Why? Oh, because the superficial's got to continue going down, and the deep one feeds the bone and the muscle. Guys, does that make sense?
Yeah.
It does, and this is the reason why you learn bones before you learn cardiovascular system. So it makes it easier for you to learn the blood vessels associated with the bones. So now, again, I'm not going to ask you to trace blood and know all those blood vessels, but should you know the physiology of blood vessels? Should you know the pressures that influence filtration, the forcing of fluid out at the arterial end of the capillary versus albumin causing fluid to move back in? Yeah, remember I talked about that, those forces that are involved. There's a formula, and remind me and I'll write it. I also have to do fetal circulations. All right. So now, since we know that the heart needs to be fed, and it needs to be fed when? During ventricular depolarization, guys? No, because the coronary arteries would be contracted on. So they're going to be contracted upon externally. Contracted upon externally. From what? From the actual cardiac myocytes that are squeezing and moving towards the apex, towards the base. So the ventricles cannot be fed blood when they're in depolarization. Do you understand? So when are we going to feed it? During repolarization. So during ventricular repolarization, and this along with breathing in causes this pressure gradient difference. It drops the pressure and it actually pulls externally, it pulls the blood vessel open and allows blood to flow to the ventricles. Did I answer your question?
Yeah, thank you.
Now, the structures that you should learn in lab, but I'll go over them with you. So if I have to feed it during ventricular repolarization, right? So coronary arteries will now feed the heart, will dilate, and thereby increase blood flow, or blood volume, and to cardiac myocytes. And don't forget, guys, that because remember cardiac myocytes, there's two types, right? There's the non-contractile type, and then there's the contractile type. So don't forget that, and don't forget about the physiology. The SA node, AV node, the SA node, atrial nodal tracts, AV node, AV bundle, left and right bundle branches, and Purkinje cells, they all have pacemaker potential stuff. They have that IF channel, that funky channel that plays a game with all three of these ions. Only in cardiac muscle. Guys, you hear me? Only in cardiac muscle. That idea of a spontaneous depolarization event known as the pacemaker potential in your textbook. Yes? If you read the textbook, they call it the pacemaker potential. Those are the non-contractile cardiac myocytes that can beat rhythmically. And don't forget that if I cut all the wiring to the heart will beat on its own faster at rest. So if you're on the operating table, if I crack your chest and cut all the wiring in your heart and watch your heart rate is going to increase. Why? Because the parasympathetic system has put a brake on the overall normal function of the autorhythmic ability of the heart to contract. Remember, cardiac myocytes, the histology of cardiac myocytes is one where they're highly striated, uninucleated, centrally located nucleus, yes? And then a shit ton of gap junctions that one cell can attach to another cell, and when one senses a depolarization event, they all do. Does that make sense, guys? Yeah, it's what gives rise to the whole EKG. So if I have an autoimmune disease towards those gap junctions, would I have problems with my heart? Everybody shake their head. Anything that disrupts the gap junction, the function of the gap junction between cardiac myocytes, guys, is going to lead to some kind of disease. If I have a problem with the door that can open and close if I have problems with the IF channel, if it's too sensitive and allows too much to be going on, will I have an increase in heart rate? Everybody shake their head. Yeah, absolutely. If I have a disease where the IF channel is not as sensitive, and so it decreases the amount of ions that flow, would I have a decreased heart rate? Everybody say yes. That's called tachyarrhythmia versus bradyarrhythmia. There are arrhythmic beats to the heart. One's slower, one's faster. And guys, guess what? These changes can happen overnight. Just like my car broke down on me in one night. The car was running fine 1 minute, next minute, riding like crap. It is what it is, guys. That's why you better thank your lucky stars every day. When you wake up in the morning, you're able to function. Because shit can go south real quick. You get me? It's all about self-phys, guys, and these cells. All right, so the ventricular depolarization, guys, coronary arteries will be contracted upon external forces of the cardiac muscle, and then of course if you're expiring, because when you expire, the pressure inside your thoracic cavity, will actually press upon the mediastinum, and then that's one of the reasons why we have the heart separate of the lungs. But sure enough, the whole they all sit in the thoracic cavity, don't they? So inspiration and expiration can aid in allowing the ventricles to be fed when they're relaxed. If you're expiring at the time when your heart is relaxing, then it's going to be a force that's going to resist flow through the heart. You see? This is one of the reasons why they tell you, anybody who knows, anybody who's a real workout nut like I was, we tell you, if you want to perform at high levels, you have to know how to match. And as the heart rate increases, it's called matching ventilation with perfusion. Well, physiologically, the lungs are already doing that. But there is a way, just like there's a way to calm yourself down, there's a way to get yourself excited. And that is one way. Pattern breathing upon very difficult exercise will aid you and aid your heart. And if you aid your heart, then the heart can feed the skeletal muscles better. Does that make sense, guys? It does. When I tell you we're going to talk about the whole cardiovascular system and how it impacts, because we're talking about what? Fight or flight, aren't we? I mean, don't get me wrong, like the heart is important. When we're asleep, it better be working. All right? And it better not be working anywhere near towards its built-in maximum, which is 80 to 100 beats per minute. So at rest, it's the vagus nerve that's keeping it at 60 to 80 beats per minute, guys. You understand? If you want maximal workouts, you better get your heart rate over 100, which means that you've got to turn on the sympathetic system. Just going in and lifting 3 sets of weight and then switching to another, you're not getting any cardiovascular exercise. So your body's not really taking advantage of the overall workout. Now, get on the bike for 40 minutes and then do your workout. How many of you do that? How many of you get on the bike for 40 minutes before you even pick up a weight? Man, that's a workout. And then, sure enough, either after or before you get on the bike, because the bike is part of the warm-up, but before you start doing those intense exercises by lifting weights, you should stretch. Why? Because you want your muscles to work at their optimum. Just like you would want your heart. And part of that warm-up, guys, is increasing muscle tone. Increased muscle tone increases venous return back to the heart, causes the sarcomere length to be adjusted just perfectly so that your heart can produce a more forceful contraction and improve your overall cardiac output per beat. The volume will increase. The force of contraction will increase. That's called Frank-Starling law of the heart. Did I tell you that, guys, before? That idea of increasing venous return and getting it to that more maximal length so that we can produce a more forceful contraction, that they give credit to Frank Starling. I believe there's 2 doctors, Dr. Frank, Dr. Starling, they figured this out. They figured out that just like skeletal muscle has that optimal stretch length to produce a more forceful contraction, sure enough, so does the heart. And we're talking about each cardiac myocyte. So you see now why, if I'm increasing venous return to the heart, and I'm stretching out my cardiac myocytes, and my cardiac myocytes are going to produce a more forceful contraction, doesn't that mean they need more glucose and oxygen? Does everyone agree?
Yeah.
So sure enough, the coronary arteries are going to feed it. They're going to feed it when? During ventricular repolarization. Not during depolarization, because the force of contraction is increasing. You think? So I'm actually reducing blood volume to the heart when the ventricles are contracted. Even more so when you exercise, but that's why you have what? You have a rhythmic pattern of atrial repolarization along with ventricular depolarization, and then ventricle repolarization, which is when you'll feed the heart even during exercise. At rest or exercise, guys, is the only time you're feeding the heart what it needs. Okay? So that's why it's important. Someone comes in and they're tachyarrhythmic, well, we're gonna give them a drug to try and get them to spend more time in repolarization, huh? And decrease. So look, guys, the amplitude of the EKG, because this reflects the overall function of the heart. Guys, you see that? Don't confuse this with the electrical activity at the SA node and AV node, right? The spontaneous depolarization event, also known as the pacemaker potential. Don't confuse that. That's about the cell, the individual cell. Just like the cardiac myocyte, it looks like skeletal muscle, increase in sodium, and then the deep efflux of potassium causes it to drop, and then you get that calcium plateau. And then potassium plays its role a little later. That's all engineered so that each cell does the same thing at the same time. There's enough time for everybody to, hey, everybody know what reveille is in the military? It's called 5:30 in the morning. Right? You gotta get up. Everybody get up. No excuses. Get up. We don't care if you're peeling potatoes and working in the kitchen, or if you can go out there jumping off platforms and learning all this special forces stuff. Everybody gets up at 5:30, and you got 15 minutes to brush your teeth, or 10 minutes, 10 to 15 minutes to brush your teeth. What they call shit, shower and shave, right? That's it. Then you go back, and it's a 5-mile run. You get me? But they give enough time for everybody to get out. Well, sure enough, that built in within each cell is designed so that all cells can get together before they contract in unison. And that's different from skeletal muscle, isn't it? Yeah, because skeletal muscle has different muscle fibers made by a series of myoblasts that fuse together. And some of the muscle fibers that are in skeletal muscle have one nerve. It's called a motor unit. And then there's another nerve that comes in to connect. They're all individual. That's how I can pick this up and apply a certain amount of force versus picking up a desk, versus picking up this chair, versus picking somebody else up. My muscle has the ability to elicit a more strengthful contraction because it has more motor units. That's not cardiac muscle. Did everybody hear me? There's only one set of wiring in this guy. And that's the wiring I just went over with you. Got me? And it's only getting input from now this is what's really cool. Watch this now. So cranial nerve number 10, the vagus. Oh, wait. Cranial nerve number 10, the vagus. Right? Versus sympathetic postganglionic fibers. And the vagus really is what? The definition of that is parasympathetic preganglionic neurons. Postganglionic neurons, sorry. Parasympathetic preganglionic neurons. Because they're going to go to the wall of the organ. And so what happens? Cranial nerve comes from cranium. Okay? Sure enough. What did we say? We had SA node? We had AV node? And then the atrial nodal tracts in between, traveling and then converging. Right. And then so what happens? The vagus nerve will input on SA node and AV node. Sympathetic, and there's a left and right, and I don't want to get into that with you. I just want you to know that left and right sympathetic nerves are innervating directly. Left and right vagus nerves are going to innervate the SA node and AV node of the heart base, and that's how they'll modulate and decrease those IF channels. It takes longer, so you get a normal bradyarrhythmia. All right, you're slowing the heart rate down. That's what we're doing naturally, guys. And this is predominant. This predominates. At rest, vagus predominates. And if you remember, that's acetylcholine released on them. Right? That's acetylcholine released on them. So those preganglionic neurons are going to release acetylcholine. There's going to be a secondary neuron that's in there, real close to the organ, that's going to also release acetylcholine. Okay? So then acetylcholine will work to reduce the overall rate of the heart's contraction. And that's what we're at rest, that's predominant. Okay? It's like the third time I said that. Then sympathetic neurons, look, red for stop, green for go. You got me? So sure enough, the sympathetic nervous system will also input, and there's a left and right sympathetic neurons that are coming into the heart, and they'll innervate both the AV node and the SA node as well, because we know that that's where the pacemaker is. That's where we have to stimulate this if we want to increase it during exercise. You get me? So now, there's one other thing that sympathetic can do. And sympathetic guys can go directly to the heart, to the ventricles of the heart. Okay? Parasympathetic can't do that. And this is why the force of contractility can actually be modulated by sympathetic nervous system. Now, why would I want that? Because we're talking fight or flight. Everybody got me? And that would make sense. When the heart is being called upon to deliver more, the sympathetic nervous system is going to make sure of it. Just in case. We understand there's a Frank Starling heart principle within each of the cardiac contractile myocytes for them to increase overall cardiac performance. But the sympathetic, it's like a redundant little backup. Just in case you didn't get the memo, sarcolemmas and Frank Starling principle of the heart. All right, bet. We got hormones that are going to stimulate directly and act to increase the hypertrophy of the cardiac muscle to help increase overall cardiac performance. So every time you exercise, your heart's cells are getting a little bit stronger because they're being told by the sympathetic nervous system to increase the amount of actin and myosin inside the cells. And that's why a well-conditioned athlete, like someone in the military who wakes up every morning and runs 5 miles, that's why they have a lower than normal heart rate or cardiac output. Because at a lower heart rate, they're pushing more volume out normally. Because their cells now. Is there disease behind this, guys? Yeah. And I can tell you this because I can look at my Caribbean people and African people, right? Because we all, one way or another, we all got brought over to these islands. So what happens within Hispanics, Latinos, and African Americans? It has to do with diet more so than anything else. We're at risk for what they call cardiac hypertrophy. Now, cardiac hypertrophy is we already said, if you work out regularly, cardiac hypertrophy is a normal physiological condition. But there is a case of disease where it's called concentric cardiac. They're called myopathies, first of all. And there's all kinds of myopathies. All this means is pathology and muscle mass. So your pathology can be a skeletal muscle, like Duchenne's muscular dystrophy. Or Becker's muscular dystrophy. And what does that have to do with anything? Okay. So remember skeletal muscle, guys? Actin and myosin. And then remember that collagen is outside the cell? So, really basic. Any cell that wants to contract its own muscles, it's got to have actin inside, and then there's got to be collagen outside, and right in there, there's this huge protein. It's huge, guys. And it's called dystroglycan. Well, within that, on the intracellular side, there's another one called dystrophin, which is a component of the larger dystroglycan complex. And the dystroglycan complex connects to collagen now. So for any muscle to work, period, it's cardiac, skeletal, or smooth, you gotta have proper dystrophin inside the cell associated with that larger dystroglycan molecule that would allow you to connect actin to collagen. Extracellular versus intracellular proteins, guys. You see that? Chapter 4, chapter 3. And then so when actin works in the sarcolemma, then it's going to pull on the dystrophin, which will pull on the dystroglycan molecule, which will pull on the collagen, and that will cause some form of what? Mechanical event. You get me? If this collagen is associated with tendon that goes to bone, then you're moving bone across the joint. But if it's cardiac muscle, then you're doing what? and ventricular contraction. So, as you can see, look it up. You see, I'm not lying to you. Muscular dystrophy. That right there. Dystrophy. Muscular dystrophy, guys, has to do with what muscles affected. Are we talking about skeletal muscle, cardiac muscle, or are we talking about both? That's why there's different variations of the disease. There's Duchenne's and Becker's. Okay? So muscular dystrophy is telling you, oh, it's dystrophin's bad. Oh. Or something's wrong with the dystroglycan complex. So if that's the case, then when my muscle contracts, can it pull on collagen and actually contract mechanical event-wise? No, and if we're talking about heart, then that means we can't generate what? A change in pressure. And if we can't generate a change in pressure, then we can't push out volume. Does that make sense? That's the basic cardiac cycle, isn't it? Remember, because the heart's performance, we can't measure it through length, tension. We can, but to do it, you'd have to, hit them, down, and pull their heart out, and hook it up, and put it on a transducer and record it, right? We don't want to do that. So what do we do? What options do we have? Anybody? Now I'm going clinical. My EMT in the back. EKG is a good one, but it's not good enough. Because it's complicated, a lot of people don't know how to read them. Go. Cardio. All right. What? Sex. Echocardiogram. An echocardiography. What's an echo? Anybody know how an echo? What's that based upon?
Bounces waves.
Balance. It bounces waves. It's the Doppler effect. Physics. Now, the best technical tool to measure overall cardiac performance is now called the 3D echo. And not only does it give you a perfect picture of the heart as it's functioning in the chest without you having to cut it open and hook it up, it assigns color. So now they call it the colored 3D echo. And now check it out. Based on Doppler effect, blood coming in has one color. It's assigned one color. Blood going out is assigned another color. So you can actually, the machine, all you have to do is put them on. The machine will kick back and tell you what the ejection fraction and what the overall cardiac output is on the heart mass. And it'll tell you something's wrong. Now, do you see why I tell you? Every child that comes into a pediatrician's office, if they expect to play sports, the doc shouldn't be doing no EKG. The doc should be doing a performance echo. You know what I mean?
Yes.
You want to perform? Does it make sense? You guys, you want to perform? I'm going to take a picture of your heart at rest? No, hey, I'm your doc, man. I care about you as a patient. I'm going to take a 3D performance echo. I'm going to give you a stress test. You're a 12-year-old. You're coming to my office. You want me to sign on the dotted line? I'm going to put you on the hardest treadmill setting that I can. Because you're a young person. You're going to be kicking out cardiac output up to 180. Mm-hmm. So I'll put you on there and make sure before I sign on the dotted line saying that you're okay. Why? Because African Americans and Hispanics are at risk for concentric cardiac myopathy that doesn't get diagnosed until they're 18, 21, 23 years old, and then they're what? They're falling dead right in front of their teammates, guys. And it's happened. 3 African Americans in the past 2 years, basketball players. One of them, they're playing on an NBA team, an NBA farm team for I don't know how many years, and he was supposed to be going up. So he had been there for a few years, he was supposed to be going up. He crashed right there in front of his whole teammates. There wasn't a doctor anywhere in the facilities. There was no EMT anywhere in the facility. By the time they got there, they didn't have a cardiac defibrillator, none of this stuff. Len Bias, sniffing cocaine. The night before, he had signed with the Boston Celtics, and he died. He'd done so much cocaine, he had cardiac, what they call cardiac hypertrophy, which is a form. So just like muscular dystrophy is a form of myopathy, well, concentric cardiac hypertrophy. Now listen to the word. Hypertrophy is an increase in the size of the cells. Yeah? And concentric is it's overall growing around. And what happens is over time then it reduces the overall volume. And remember what I told you, guys. The volume on the left side has to equal the volume on the right. these volumes on right side volume must equal left side volume. Every moment. Whatever the right side heart kicks out the lung, that same amount better be going to the left side heart for the left side heart to pick it up and kick it out. If the left side heart gets thicker because of this disease, then you get a reduction in the left side volume. Where is that fluid going to go? It's going to stay inside the heart. You understand? That's going to increase the pressure. Now you got a pressure that's going to prevent fluid from moving from the right atria into the left ventricle. So it's going to accumulate in the left ventricle. See that, guys? And then it's going to back up and accumulate in the lungs. Okay? And these people, they'll be coughing. What would they be coughing up? Blood. What do we call that? Coughing up of blood, not throwing up of blood. Emesis is throwing up. So coughing up of blood would be what?
Blood in the lungs.
No, hemoptysis. Called hemoptysis. So when you cough up blood, and you see blood, that's hemoptysis. Okay? Either you got lung failure, you got some form of bronchogenic carcinoma of the lung. Alright? That's not good. Yes? Yes. Yeah, I'll do that now. So are there any questions on this, guys? So there are others. There's one called dilated cardiomyopathy. And what happens there is, in some people, that increase, that over time, that decrease in volume causes an accumulation of fluid. And then even though the heart is increasing its thickness, for some reason the volume is so great that it starts to stretch the sarcomeres. And then what happens when the sarcomere length goes to shit? And there's no overlap, no contraction. And that's called dilated cardiomyopathy. That's when the heart no longer, it's just like a bag with no ability to contract. More like a vein in an artery. Make sense, guys? Mm-hmm. It does, doesn't it? Because there's a limit to how far I can stretch. And if every one of those cardiac myocytes, if I stretch every one of those sarcomere lengths, so that actin, there's no overlap between actin and myosin, and the heart can't contract. And that's called heart failure, guys. That's what heart failure is. The heart's inability to contract would lead to a massive accumulation of fluid. And what did we say, guys? If fluid